I'm delighted to be with you. I thought a lot about what to bring to share with you today. I think this topic is, of course, I think it's fascinating for many reasons. I think it's fascinating that thinking about the science of communication because I'm a science communicator. I wrote a book. I've placed behind me How to Change. I spent a lot of time thinking about how to communicate about the science of behavior change for a wide audience for that. I host a podcast, Choiceology, and I think a lot about how do we communicate insights from behavioral science to a wide audience for the purpose of that. Also, the best cited article I ever wrote accidentally, even though it's not really in my core area of expertise, is an article about what content goes viral online. And it turned out to have a lot of implications for what kind of science stories people share. And actually sharing science stories in the New York Times at the time of our analysis about 15 years ago was extremely common. It was the most likely section of the New York Times to go viral back then, which was something really interesting we found. So I thought about a lot of things that I could bring. And what I decided to bring is some work that has been a major focus of my research initiative over the last few years. And it's actually really about communicating to people about vaccines, which I think of as science, right? Vaccines are one of the most amazing results of science that has ever existed. And it has unfortunately been challenging to communicate about them effectively. So I'm going to talk to you today about a bunch of work my team has done to try to improve our understanding of how to communicate about vaccination decisions. And I'll talk about a new methodology we've developed in the course of doing that. Okay, so I'm going to pull up some slides and hopefully, oh, no, I'm showing them to myself, but not you. So let's do that better. You'd think after all these years. First, you're going to see them not in sharing mode, and then I will share them. Here we go. All right, hopefully that's working again. I'm looking at your little faces to see if anybody, yes, okay, I see the thumbs. Thank you for giving me the thumbs. That's very meaningful to me. Okay, all right, so the question I'm going to answer is how can we most effectively communicate with the public to encourage vaccination? And I'll talk about a mega-study approach to finding solutions. All right, I doubt that at this point in time, I have to motivate this very, in a big way, because we have all now lived through the pandemic and lived through the vaccine mess in the United States and watched all the different ways that different organizations tried to encourage vaccination. But I'm going to take you back in time very briefly. You may or may not remember we were all eagerly awaiting vaccine rollout, or many of us were eagerly awaiting it, hoping it would bring the end and bring us back together as you are today. At the time when vaccine development was really, it was clear that that was going to work out and we were going to get a vaccine that would help us get out of the worst part of the pandemic, a lot of people were hesitant about it already. So this is just a graph showing you the percentage of people over time who were saying, yes, they'd take a vaccine immediately if it were available for free versus no, they wouldn't. And you can actually see that interest in vaccination was declining over time for a little bit. There was a fear of politics playing a role in a rush, but it was never as high as we wanted it to be. Now, P.S., let me just say that now we're at 81% of Americans who've had at least a first dose, which is pretty great. But everybody was nervous about this. We knew that the slower the rollout went, the longer we would be in this stasis position. So there was a lot of talk about, Operation Warp Speed, let's speed up making the vaccines. Then there started to be talk in the summer of 2020, not only about making the vaccines really fast, but about how are we going to distribute them efficiently. That's going to be a problem. We need to think about supply chain issues. But actually, you may have noticed crickets around science communication. I would guess that a lot of you were thinking about that because this is your area of study. I was really worried about it. And my co-authors and collaborators and I, wrote an op-ed in USA Today pointing out that you actually have to figure out how to convince people to take the vaccine and communicate about it effectively. And we needed to make a major push on that front, just as there was a push being made on development of the vaccine and a push being made on supply chain and distribution issues. We decided we would try to step into that void and try to accelerate knowledge in this area. And I shouldn't call it a complete void because certainly we know something about communication and vaccine communication, but we knew surprisingly little about what would be best. And it seemed like a moment when we really wanted to get this right. All right, so one challenge, and that's not going to be the focus of our work, is persuasion, right? How do we convince people who are really hesitant that this is a good decision? Another challenge, though, and this is what we saw as really low-hanging fruit, was actually not the persuasion challenge so much as the follow-through challenge. So it turns out that in a lot of important behaviors, particularly in health, when we're sort of on the fence, open to something, but it sounds a little bit unpleasant, that we see a lot of issues with follow-through. People are like, yeah, sure, I'll do it, but then they don't actually. And we thought we could focus particular efforts on this. So again, intentions tend not to line up well with our behavior. There's some data on this in the area of vaccines as well, but these are some better studied areas where people are asked specifically, what is your intention? And then later, did you actually do the thing you said you would do? And you can see that intentions don't line up that well with follow through. Okay, so we thought it would be really ideal actually to study this in the context of flu vaccines because we wanted something similar, a similar decision, but we didn't yet have COVID vaccines and we wanted to be prepared with insights. So the work I'm going to show you today, I'm going to talk about 4 different studies. First, I'm going to tell you about a study I did over a decade ago, long before COVID, that whet my appetite for thinking about how communication in this realm could be effective in talking about vaccines. Then I'm going to share 2 studies we ran to encourage flu shots in the fall of 2020, where we were trying to develop messages that would be effective against flu or COVID and testing them on flu. And then finally, I'm going to conclude by telling you briefly about a new study that actually you will be the first audience I have ever presented the results to, based on a massive experiment we ran this past fall to try to encourage booster shots. Okay, so flu vaccine, that's where I'm going to start, but we will get to COVID vaccines, and it's largely motivated by wanting to understand that problem. Okay, so I'm going way back in time to just tell you where I realized, okay, communicating about this about vaccines is something that behavioral scientists can help with. So this is research that I did in actually the study was run in 2009 when probably you were all babies, not quite, but you were very little. And it was a pandemic year, believe it or not. It was the H1N1 pandemic. And that pandemic was not as severe as COVID, but they did come up with a vaccine that was mixed with the flu shot. So actually everyone who we were trying to encourage to get a flu shot this year would also be getting a pandemic shot. It was a combo 2-for-1. And we partnered with a company called Evive Health that sent health reminders to the employees of its client firms. And one of the kinds of health reminders they sent where we partnered with them was this reminder to get a flu shot at an on-site workplace clinic. And this is what their standard mailing looked like. It had a lot of text. You might be already wondering, oh gosh, we should be able to improve on that. It's a little too text heavy, but it has this blue call out box, which is where we're going to run our experiment that tells you about the free flu shot clinic and the locations and times. So they sent these workplace flu shot clinic reminders every year, and they sent them in the fall of 2009. And we ran a randomized controlled trial with about 3,000 employees at a large Midwestern utility company. And at the time, actually, flu shots weren't recommended for everyone. That's changed. They're now recommended for everyone. But at the time, they were recommended for people over 50 with chronic disease. So that's who we focused on. And there were actually 62 different sites. This was a distributed workforce. And they were clinics that were held for 1 to 5 days. So that's going to be another interesting source of variation here. So we tested 3 actually different versions of our mailing. The first version is a control version and just says the dates and times where you can get a free flu shot. That's very simple. We said, we think we can improve on that. One thing we know from behavioral science is that helping people make concrete plans about when and where they'll follow through on an action increases follow through because now your commitment is firmer, it's harder to procrastinate, and it's less likely you'll forget when you've made those detailed plans. So we prompted people in one version to just plan the date, which of the days when there was a multi-day clinic were they going to go. But note that a day leaves a lot of wiggle room for forgetting and uncertainty because we haven't figured out the date and time. We just know this day, and you can't exactly put a whole day on the calendar. So we had another version that we thought would be a bit better, where we asked them for both the date and the time. Now we have a really precise cue, a really specific moment to put on the calendar. And we tested all 3 versions of this mailing. And I should note that this isn't an appointment card. So you're being prompted to write this down on a mailing you get at home, but there's no way to send it back. So you're not scheduling an appointment. You're just making a plan privately for yourself. And I think that's important because I think there'd be very different psychology if you're sending back a mailing and saying, oh, this is my scheduled time, and knew someone was going to be waiting for you there. This is easier to implement. So the exciting news is that prompting people to make a plan helped. The time plan group went to get a vaccine at about a 4 percentage point, exactly a 4 percentage point higher rate than the control group. And the date plan was intermediate in between. So that was really exciting. And PS, I should also say the effects were about twice as large when we zoom in on work sites that had multi-day clinics. Excuse me, I said that wrong. When we zoomed in on work sites that had one-day only clinics, where forgetting was particularly costly, the multi-day clinics, the planning wasn't nearly as valuable, but at single-day clinics, where if you forget to go on Tuesday at 3 p.m., you're out of luck because it's not there on Wednesday. That's where we saw about an 8 percentage point boost. So that was really exciting. And it made me feel optimistic that come 2020, if we put a lot of good minds on the task, we could generate more insights of this nature that might be able to really make a dent in the challenge of encouraging COVID-19 vaccination. So how are we going to do this? Well, this felt to us like a problem right for what we call a mega study in my research group at the University of Pennsylvania. So a mega study is a massive randomized controlled trial that, instead of testing a single idea or a couple variants on an idea, like the test I just showed you, actually tests many different ideas at once. So we test dozens of messages, perhaps, instead of a single one. So the nice thing about doing a mega study, as opposed to just single tests of a single hypothesis, is this allows for comparability of results across studies, right? So if I'm trying to figure out what's the very best message to send to encourage COVID-19 vaccinations, and I just run a bunch of different separate tests, and different teams are testing their own pet hypotheses in different populations, it's really hard to figure out, well, in a head-to-head competition, which one actually wins. So that's going to be really important in this context. It can also be run as a tournament, so you can draw people who are interested in publishing in different outlets, and they can each sort of have their own individual study that isolates what they're interested in, but you can pool all of those and launch them at the same time. So you can attract economists, psychologists, communications researchers, doctors, lawyers, sociologists, whoever you'd like, and they can each be sort of an isolated team with a little study within this mega study. It obviously speeds things up. You have, one coordinated process rather than a bunch of separate processes for running their own tests. And finally, I think one exciting thing about it, although I'm not going to exploit that today in this talk, but just to whet your appetite, is that it is really ideal for thinking about sort of machine learning applications, like figuring out what works best for whom, how can we tailor messaging to different subpopulations. Just to note that this is not coming completely out of the blue. So a similar idea to the Megastudy revolutionized AI years ago. So something called the Common Task Framework about 15 years ago now became really popular, where researchers would compete to solve the exact same problem. Say, how are we going to build a better image recognition engine using exactly the same constraints? So they'd have the same validation method and the same data set. And so we could, people could compete head to head on exactly the same problem. That really helped it helped level the playing field and accelerate progress. And of course, there's also been lots of research on things like scientific tournaments, which are similar in flavor, but don't typically involve random assignment. So this is going to be a bit of a riff on both of those ideas. All right, so the first study we ran was a mega study with Penn Medicine and Geisinger Health, two local health systems in the Pennsylvania area. I'm at the University of Pennsylvania, so it's conveniently located, and Geisinger is just a little ways away from us in central Pennsylvania. So what we were interested in doing was encouraging patients who were going to be coming in to see their primary care doctor. That doctor was going to try to convince them to get a flu shot, and we wanted to see if we could prime the pump. Essentially, could we send messages in advance of that doctor's visit, text messages to patients that would increase the likelihood they accepted their doctor's recommended vaccine? So we're going to have about 50,000 people in this trial, about half and half Geisinger and Penn. They're skewed a bit female, a bit older, fairly diverse demographically, and right around the national average in terms of their take-up of the flu shot the prior year at 47%. All right, so what we did is we randomly assigned these patients to one of 20 different experimental conditions, which had an average of about 2,300 people in them. So this is a bit bigger than the Evive study. There are going to be 19 different communication strategies we test, and one holdout control group, which is getting reminders to come to their doctor's visit, but not reminders about being offered a vaccine and encouragement to take that flu shot. And the outcome we're going to measure is whether or not the patient accepts the flu shot at their doctor's appointment, or goes to a pharmacy and gets a flu shot in the 3 days leading up to it. And the reason we do that is because we start messaging 3 days before. And if people are so excited by our messages that they run out and get a flu shot at the pharmacy, we want to make sure we're capturing that. And the doctors do ask, have you already had your flu shot and when and where? So that gets captured in the system if they did that. PS, mostly that's not what's happening, but we did capture that. And then people's experimental condition, it determined which text messages they got in the 3 days leading up to the appointment. And we had 26 different scientists who designed 19 different messaging treatments to test different hypotheses. And if I were to list all 20, I think we wouldn't have time for questions. And I have 2 other studies I want to share. So instead, I'm going to give you sort of a sample, and I'll tell you what came out at the top and the bottom. So the kinds of things were very different that people tested. One idea was, can humor be used to boost vaccination rates? What if we tell people a joke? And we said, have you heard the one about the flu? Don't spread it around. And then, be sure to get your flu shot. And the idea is to make people laugh, feel like it's lighthearted. Maybe they'll repeat it to their friends. It's more memorable. We invited people to dedicate their vaccine to a loved one. Maybe that would make it more appealing. We often run a marathon or fundraise for loved ones. Maybe dedicating a vaccine to someone would make it appealing. Another idea was to just use the language of sort of defaults, tell people a vaccine has been reserved for you, to make it feel like it's recommended and it's literally already been set aside. It belongs to you. People tend to value things that belong to them more than other odds and ends in the world. So lots of different tests, but those are a few. And here are the results. And just to give you a sense of what you're looking at, the x-axis is a regression estimated point estimate of the rate at which people got vaccinated. Each dot represents a different experimental condition. And the blue line shows you what happened in the baseline control condition where people weren't getting these reminder messages. And you can see, good news, all the reminders are to the right of that blue dotted line. So the point estimate is that everything was better than nothing, but not all of them were significantly better than that baseline. About a third of the treatments significantly outperformed baseline in this study. And the best performer increased vaccination rates by about 11%. And it told people in simple language that a vaccine had been reserved for you. It used that endowment effect language. We call it the endowment effect when people value things more than that they already believe belong to them. And I'll just show you very simple language. 72 hours before the appointment, you get this very sort of, I'll say, boring, non-interactive text message telling you it's flu season and a vaccine's available. And then 24 hours before the appointment, a vaccine has been reserved for you. And actually the 3 top performing messages all used that reserved for you language, and none of the other messages did, which was a pretty strong result. So a few key takeaways here. We do see evidence that these behaviorally informed reminders are able to help nudge vaccinations at a higher rate. The best performing message used this reserve for you language and had an 11% boost. And when we did an analysis of what were the components of the messages that perform worst and least, the 2 big things that emerged from that were this reserve for you language, as I mentioned, was in the 3 top performers and none of the other messages. So that seemed like it really propelled vaccinations. And then things that we thought that would work that really didn't were anything surprising, casual, or interactive. And in fact, the joke message that I mentioned to you was the worst performer. So patients seemed to find it odd and not helpful, and they didn't respond positively when they got communications from a healthcare provider that didn't feel like what they were used to getting in that venue. Okay, so we did a second mega study, also in the fall of 2020, also leading up to the COVID vaccine rollout, also motivated by the desire to figure out what we could about messages. This one, though, was with Walmart pharmacies. So the first was with 2 healthcare providers. That was a great population, trying to convince people to get vaccines when they see a doctor and it's offered to them. But we wanted to tackle another big challenge that we thought might be even more like or more akin to what would happen with COVID vaccines, which is, what if you're not already scheduled to see a doctor and all you have to do is just put out your arm? What if you now have to actually drive to a pharmacy or a vaccine site and request a vaccine? Would we need to communicate with you differently in that context? So here we're going to be communicating with Walmart pharmacy customers and encouraging them to, get in the car or walk down the street, show up at a pharmacy and ask for a vaccine because they don't already have an appointment to see someone. So this is again going to be a text message study. And we're only, unfortunately, in this study, going to be able to look at people who'd gotten a flu shot from Walmart the previous year due to FTC regulations about text messaging and concerns about marketing. So it's a little bit more limited in terms of who we're communicating with. But it's very large sample. So we have almost 700,000 Americans in the study. We know less about their race, but we know, again, they're a little bit more skewed female, a little older on average, to have been eagerly getting their flu shot the prior year. And we're going to do a pretty similar design to what I just showed you. Here we are going to have 23 different experimental conditions. Though note that we're going to have 30,000 people per treatment, so an order of magnitude more statistical power to detect effects. We're going to look at who gets a flu shot before the end of the calendar year, and these messages are going to go out in September. So we're going to send one message on September 25th to everyone who is in one of the treatment conditions, the control condition, which is business as usual, not get a message encouraging them to come in and get a flu shot. And then they'll hear from us again, at least possibly one more time, or maybe not at all, at most 3 days later. So each experimental team decided how many times to contact people, 1 or 2, and on what dates, September 25th, and 1 day later, 2 days later, or 3 days later. And there were 24 scientists here who designed 22 different messages to test different hypotheses. And there was some overlap with the other study in terms of what we tested, but there were some differences. So one question one team asked was, what if we describe vaccination as a way to protect family and friends? Would that be more effective than focusing on it as a selfish act? Does learning that an increasing number of Americans are getting flu shots make them more appealing, so it feels like a fad, a trend you want to join? What if we get people to sort of ruminate about all the places they could catch the flu? Would that make them realize, oh, this is really a risk for me, and be more willing to get it? So here's what happened. So hopefully this will look kind of familiar in that the x-axis is again showing you the estimated rate at which people got their vaccine. The blue dotted line is again the rate of vaccination in the control group that didn't get a message. Now we're really well powered, so we have much smaller standard errors. And as a result of that, we can confidently say here that actually 100% of the messages outperformed the baseline control. So we're beating no reminders regardless of what message we include. So that's exciting. Reminders are definitely working here. Interestingly, we weren't allowed to say the word reserved for you in this experiment, but instead we used waiting for you. And that was because Walmart was a bit worried about stockouts. They felt like reserved for you promised that it was definitely going to be there. Waiting for you, maybe there's a little more wiggle room. It's not, oops, it was waiting. It's not waiting anymore. Actually, I believe 3 of the 4 top performing messages said a flu shot is waiting for you. The rest didn't. So this sort of ownership language, again, rose to the very top of the heap in our second study. Really simple message was our top performer. I mean, just look how simple that is, right? The initial text, we have to include this stuff about opting out. It says they help, come and get your flu shot. And 3 days later, remember, a flu shot is waiting for you at Walmart. So key takeaways from this, we have some more evidence that behavioral science can nudge vaccine adoption. 2 big things stood out in terms of our analysis of the overall performance of messages. First, 2 reminder messages systematically outperform 1. So it's better to hit people with multiple reminders within 3 days rather than just a single. Nagging works. And that waiting for you language, just like reserved for you in the prior study, really seemed to help. Those were sort of our big takeaways. And one exciting thing is that this work did end up getting used by a team of scientists who actually were part of the team that helped us develop this Megastudy. And it was tested early on in the rollout of COVID-19 vaccination to use the same kind of ownership language. And a paper published in Nature showed that this outperformed standard reminder messages. And so that was really exciting. So we get to validate that this idea or sort of simple communication strategy we had developed indeed helped. And it is now in very wide use. You may be getting messages like this. I have received from Walmart, Walgreens, CVS, Rite Aid, and different hospital systems. People are constantly sending me pictures of their reserved for you or waiting for you text messages, which were used widely this past year. So that was really exciting. I'm going to tell you about one last study before I take questions. And this is the really hot off the presses. This is a working paper that hasn't been submitted yet. You were the first population that is going to see the results. And the question we wanted to ask here was around actually COVID-19 vaccination decisions, but specifically boosters. So, and we did this study this past fall, and you may have noticed that booster take up this past fall, while this was recommended and particularly important for older and immunocompromised, it wasn't a super popular booster. People seem to be getting a little vaccine fatigue. So we thought maybe we could help. And we wanted to test text messages, but we thought we'd actually test them against a tool that had been rolled out and invested in heavily by the government, which is actually just providing people with free rides to and from a pharmacy to get their vaccine. So the key research question, actually, I would argue here is, do free rides to and from the pharmacy for a vaccination appointment add value over and above messaging and good communication? And also we're going to test another set of communication strategies that try to evolve a step beyond the sort of reserved for you, waiting for you messages that worked so well. So we keep getting bigger. Each study I show you is bigger than the one before. It's like a major growth curve. As we build credibility, we get larger and larger partners. So we did this study with another pharmacy that I cannot name yet. There's a pharmacy whose patients had agreed to receive SMS messages and had received a previous COVID vaccination at the pharmacy. We had over 3.6 million people in this experiment. There were actually, they're 40% male, and their average age is a little younger here. And we are focusing now on 65 major US metropolitan areas where Lyft had good service coverage. So we did not do this in extremely rural settings where it wouldn't have been possible to take advantage of a free ride to and from your vaccine appointment. So patients in this it was a smaller, even though it was very large in terms of the population, we tested fewer ideas because we felt we were kind of honing in, and we wanted to just power ourselves well. So patients were randomly assigned to one of 9 conditions, 8 treatments and 1 control. The free ride group was a little smaller because we were worried about how expensive that would be. So just to make sure we stayed within budget, we only gave out 50,000 free rides. So then there was an order of magnitude more patients in the other messaging only conditions, about 500,000 each. And here we're looking at who gets a bivalent COVID booster shot within 30 days of the start of the study period. And the experimental condition to which we assign people determined which, if any, text messages and free rides patients receive from the pharmacy starting on November 3rd of 2022. So this was a November experiment, essentially, the month of Thanksgiving. And here we had 10 scientists designing these 8 different treatment conditions. And just to give you a flavor for what we tested the free ride, obviously, but we also looked at what happened when we told patients about high current COVID infection rates in their county. And in fact, we name their county, and if they're in the top 50% in the country, not only do we say infection rates are high currently, but we tell you the percentile rounded to 10%. So we would say, you're in the top, your county is in the top 10% of infection rates in the country, or top 20% in the country. Make sure you get your booster. We tried providing resources from the CDC that could combat questions about and misinformation about vaccine safety. And we tried some other things too. So our baseline message actually just used the insight we already had. So we told people updated COVID boosters are recommended for you to prevent infection and severe illness. Your booster is waiting for you. So that's the gray dot right there that you can see. That's sort of the middle of the pack, basically. And again, we're using the same scale you've gotten used to, where I'm showing the regression estimated number of patients boosted in our follow-up period here. Very tight standard errors with 3.5 million people. And the baseline vaccination rate is going to be 5% in this month-long period. So much smaller numbers that we're working with here. But we're going to be able to detect small effects. Okay, so you could probably guess by the wider confidence intervals, offering people a free ride to and from the pharmacy, telling them that it had been reserved for them, in addition to the standard messaging, did not improve on the prior message at all. There was zero value add of the free Lyft ride, which we thought was pretty interesting, given how much has been invested and how expensive and costly this is. We did find some messages that outperformed our baseline, what we had previously been saying was state of the art. So they used the same language. They told you that updated boosters were recommended, but then they added additional information. So one, the very best performer said many find it helpful to make a plan. So you may be thinking of that first study I mentioned about planning. We said And then we said and then we gave them a date, a time, and a location and said, would this work? And the date and time and location were pulled from their file to match the day of the week, the time of day, and the location where they received their last vaccine, whether it was a booster or flu shot, whatever it was from this pharmacy. So that was our best performer, which was kind of exciting. And that high transmission message about your current county was the second best performer. And both of those significantly outperformed baseline. So that was really exciting to see. And PS, our misinformation buster, was the worst performer of all the things we tested. The differences in these are very small, but they're detectable because we have such a large sample here. Okay, so this just shows you that top performer. Here we did an initial text and a follow-up 7 days later that mirrored it. And then one other thing I want to mention before I wrap up is that we did want to see if lay people or experts could predict our results. And one really interesting finding is that lay people really thought, first of all, they thought the effects we would detect were going to be dramatically larger than they were, which was interesting. So we told them that the baseline group got vaccinated at the rate of 5%. And we said, what's the lift? Like what's the increase? Lift is also the name of the car company, so that's confusing. What's the increase we're going to get from providing a free ride? And they said, oh, if 5% is baseline, you're gonna see a 31% of people are gonna go and get their vaccine when they get a free ride. So they were expecting a 26 percentage point lift from free rides, whereas we got about a 1 percentage point increase in vaccination from free rides. They thought that would be the best performer, which is interesting since it wasn't by any stretch. It was near the bottom of the pack. And then looking at other messages that we tested, they had no calibration whatsoever, but they're overestimating their performance and thinking they will underperform relative to free rides. When we asked experts who had a PhD in the behavioral sciences, they were less overconfident in terms of estimating the effect sizes, but still way off. They're also expecting free rides to outperform all the messages we tested, which was incorrect. So that was kind of interesting. Basically, everyone's bullish about how huge the effects will be even when we tell them that only 5% are going to show up and get a vaccine at baseline. So what are our key takeaways here? One, I think it's really important to note that forecasters think these free rides are going to outperform simple communications reminder messages, but they were wrong. They're also wildly over optimistic about the performance of everything we tested. And then, what's most promising, there was actually sort of, if we try to say, what's the top performer, is anything stand out, suggesting the date, time, location, as I told you, is the top performer, but actually it was really indistinguishable in terms of its performance from a couple other messages. One, communicating infection rates are currently high in a patient's county, and two, sending a message that appeared to come on behalf of the patient's local pharmacy team recommending the vaccine. So those were a couple of other ways that we could achieve nearly the same turnout. All right, so I'm going to wrap up here so we have some time for questions. I'll just say, I hope I've convinced you that these mega studies where we test many ideas at once can be really useful for improving the way we think about science communications or communicating about a scientific finding, communicating about vaccines. They have a bunch of benefits. One, they accelerate scientific discovery when we have a pressing problem we want to know how to communicate better about. We can do this fast work and really shine a light on what's best. We have these apples to apple comparisons. It reduces the risk of finding nothing useful because, when you throw many darts, one is more likely to stick. And of course, we can rule out that this is just noise. But importantly, there is noise in our predictive power as shown by our predictions. It lowers the fixed cost too, because the central organizer bears those fixed costs. And then it's really, really a light lift for scientists to participate. And they can facilitate interdisciplinary collaboration. We had computer scientists, doctors, economists, psychologists. I'm certainly missing some disciplines that were represented who submitted ideas here. And we think that this led to policy recommendations that were better than what we would have generated either doing one study at a time or certainly based on our own scientific intuition, because when we tried to predict what would work well, actually in any of these studies, we weren't that good at predicting what would work well. So it seems like the testing really was important. I do want to highlight some limitations. They're really hard to implement, right? We have a research center with a staff of 8 who's implementing these, and we're getting grant funding to do this. So the design and implementation are costly and complex, but for an important problem like communicating successfully about something like climate change or vaccine safety, this seems worth it. They do require really large sample sizes. You saw as those samples got bigger and bigger, how nice it was to have the precision to zoom in and say, oh yeah, this is really the best performer. And it even when we're seeing small effects, we could be confident in them. They require centralized coordination. And one other thing I haven't mentioned, but this is important to note, is that the effects of the top performing interventions are almost certainly overestimated due to the winner's curse. And actually the worst performers are also sort of being underestimated. So when you have a distribution, just like in a meta-analysis, there's some, you have to do a little bit of work to bring down your expectations, because outliers are just that. But this is something we can address statistically. And I can talk about multiple comparisons, adjustments, which we've done as well, if anyone's interested. So let me just say thank you. We it really took like an army to do this work. And we had some wonderful collaborators at different institutions who made it all possible, and lots of wonderful funders. So I'm super grateful to everyone who teamed up with us.